Often patients will see me because their periods actually skipped out. They hadn't seen it for months and months and months. That's actually not uncommon in the teenage years, and we typically don't get too excited about, a few skip periods here and there. Generally, it means that the brain, the system where the brain talks to the ovaries, which then talks to the uterus to shed, isn't very well established, and it just takes time to be able to do that. But I also look for any evidence that this could be related to severe stress. If the body's under stress, is there an issue with weight management, either ends of the spectrum, even over exercising or dietary extreme dietary measures. And so I'm very thoughtful about why it is that it's happening. I don't just brush it off as teenage periods, but we try to understand and make sure that it's just a normal process and that there isn't something else that's going on. We will oftentimes screen for thyroid dysfunction in young girls too, especially when there's a strong family history. It can certainly present in the teenage years. If you have a patient that has not had their menses, no period, after it's been at least 3 years since breast development, that is something that should be discussed. If there's no menses by age 13 and there's no pubertal development, that is also something that should be discussed, meaning no pubic hair, no hair under the arms, growth spurt has not happened, no breast development, and they are past the age of 13, that should be looked at. If a patient has no period by the age of 14 and they have signs of abnormal facial hair, more than just peach fuzz, but truly you can see that there's something that should be removed. That is something that should be brought to the attention of their physician. And of course, if there's no period by the age of 15, regardless of their pubertal development, that does warrant an investigation. A lot of times doesn't mean that there's something pathologic or that there's a disease process, but definitely needs to think about what's happening here. When should you alert your doctor that something is not quite right? A patient who has periods that are lasting more than 7 days, we're talking teens, we're still in the teens category. I'm going to get to my older patients in a little bit, but teens that have periods that they have flooding and gushing and severe accidents. They can't get through the school without changing their tampons or pads every hour, every 2 hours. They sit down, they have a spot of blood behind them. Their periods are coming more frequently than every 21 days. Don't suffer through these things, right? You're noticing that you're going to Sam's Club and Costco and you're stocking up on more pads and your daughters are telling you, I need more pads. That should alert you that something is happening with the periods and it needs to be investigated. This goes beyond just the concern for iron deficiency anemia, but again, self-esteem. A lot of these girls are embarrassed. They don't want to be on the cheer team. They don't want to go to the movies. It has really like a ripple effect that we want to be able to get ahead of. So the goal would be to intervene before there's significant anemia or before there's an impact on the quality of life. I see a ton of adolescent patients because of my interest in bleeding and abnormal periods. And I have a lot of parents that are hesitant to treat their children that have abnormal periods. And I would really caution you to be very thoughtful about this, to have your physicians explain the options. Some of them are hormonal, some of them are short acting, some of them are long acting, some of them require procedures, and some of them are non-hormonal. You have to weigh the risks and the benefits and the side effect profile against what it is that the patient is experiencing. Don't count it out just based on the fact that, I just don't want them on something. Think about the consequences of them not having their periods well managed. And I tell patients all the time, it's like buying a new pair of shoes. Everyone has a different size. It's not a one-size-fit-all model. You have to be able to have these open conversations. Just talking about menstrual management could be a webinar in and of itself. So I'm going to move quickly on from here, but just to know that it is okay to offer patients, even the young patients, options. Other menstrual issues, complaints of painful periods, a term that we call dysmenorrhea. Primary dysmenorrhea means that it just happens. It just happens for no reason. It's because the periods are maybe a little bit more heavier. There's a lot of inflammation, easily treated with anti-inflammatories. But it's the secondary dysmenorrhea that we really need to think about. So secondary meaning that there's a cause of this. There's something that we need to investigate. And we typically don't think about endometriosis in teenage patients, but in one 2020 study, they looked at 1,000 teenagers with pelvic pain, and they actually diagnosed endometriosis in 64% of those patients. So this is something that we absolutely need to think about in this patient population. Something else is a structural problem. Is the blood just not flowing out freely out of the uterus and out through the vaginal vault? Is there some sort of obstruction? I showed a little picture down here of a septum that sort of like two kidney beans area. It's really that division between the two should not be there. And it would require a small surgical procedure to remove that obstruction. We have reasons to suspect this. We would not screen for this on any and every patient. That's where that history taking comes in, and really evaluating patients to get to the bottom of what's happening, okay? So painful periods can happen, something we call primary dysmenorrhea. No real reason for it, just common. Periods are achy, inflammation. We treat it with anti-inflammatory medications. But secondary dysmenorrhea should definitely be on our radar, especially in families where you're like, my mom had endometriosis, my aunts have endometriosis. They got diagnosed well into their 30s, such a long time before we diagnose them. We should be thinking about that in our young teens as well. And we have gone to extreme measures to take a look inside the abdomen and pelvis with a camera to diagnose it in patients. So don't feel that something can't be done just based on their age. Having conversations about your individual risk before you become pregnant is absolutely critical. And much too often in the Black community, we show up when we're already pregnant. We have access issues, we have insurance issues, we have challenges that preclude us from getting there early and before we conceive. But in the event that we can, we should absolutely do that. That preconception, I always take the opportunity at your annual visit to talk about these things, because I know that it's often hard to get you again before you actually conceive. That is my one chance to be able to have these conversations. And so I will start by saying, are you pregnancy preventing? Or are you pregnancy planning? And then they'll say, I'm not really preventing. And I'm like, well, then you should be planning, right? Because if you're not preventing, anything can happen if you're sexually active. And so I take that opportunity to talk about their medical history, if they're on any medications. I talk about which medications would need to be changed if they were to conceive. I take a deep dive into their blood pressure. I screen for diabetes. I really try to take that opportunity to help them manage any chronic conditions at all that I can before they conceive. And it makes all the difference. So don't be offended if your gynecologist takes a little bit of a detour from your annual visit to talk about pregnancy planning if you have not declared that you are preventing. I think it's just the responsible thing to do, and it just gives you information. You can use it or not use it, but I think it's helpful. Another big thing in this age category is abnormal uterine bleeding, right? So I think, 20% of my daily clinic visits are centered around just funky periods, periods that fit the criteria that we described for the teens. They last more than 7 days. You have flooding and gushing. You're calling off work. You have iron deficiency already. You're eating ice because you just can't help it. You feel tired in the afternoons, and all of these things are centered back to the fact that your periods are not normal. And when I see you at your annual visit, again, I take that same detailed period history, and then I try to figure out why is this happening? And there's an algorithm that we use for this, and it's called Palm-Cohen. Is there something structural? Are there polyps in the uterus? Is there something called adenomyosis? Are there fibroids? That leiomyoma word is a fancy word for fibroids. Should we be concerned about abnormal cells in the uterus, precancer or cancer? And then are there non-structural things? Is there a bleeding disorder? Is there PCOS? Or is there not ovulations? Is there an IUD in there or a next one on the arm that's just making the periods get chaotic? And so these are things that are introduced at the annual visit, might require other visits to follow, so that it really has its due time to be able to address these things, but certainly it should be brought up at your annual visit.